It's with great pleasure that I would like to introduce our next keynote speaker, Professor Ruth Endacott, who is the director of the Royal Devon Exeter Clinical Skills School and also a professor at Monash University as well. So Ruth is a critical care nurse by background and has extensive experience in practice, education and research related to critical care. She has extensive experience in developing research of clinicians using a range of methodologies, but particularly focusing on safety and quality of care and around recognising the deteriorating patient and end of life. So I'd just like you to welcome Ruth to the stage.
Thank you. I know I was introduced this morning as being from Australia. Well, I'm going to Australia next week, and so these are my two sea views from my different places of work. Very, very fortunate. But yes, my day job is running a clinical school, which is a link between health service and university, and it's a very privileged position to be in. So I'm speaking to you for a wee while now. Got the Belfast lingo, about outcomes from simulation. This is a really thorny issue, isn't it? It's one that we think we've grasped it, and then suddenly it disappears, and we think, oh, maybe we don't get it after all. So we're going to just spend a bit of time thinking about, well, okay, where are we now with outcomes? Where do we need to be going next? And what are the sort of things that are influencing all of this? And I'm sorry, I'm not Mark, so you might have struggled to stay awake. So if I see lots of people nodding off, I'll come and bang the microphone or something. So anyway, I hope you get something out of the next 25 minutes or so. So in terms of outcomes from simulation, if we think about simulation-based education, really the goal, and I always think Gabba's original definition of this is probably the most useful. It's about replacing or amplifying real experiences, isn't it? And replacing those with guided experiences. And guided is actually a really important word in there, isn't it? I don't know about you, but I've seen and actually been part of some simulation that's not been at all guided, and it's been quite scary, and it's not even been guided afterwards either. So I think guided is quite an important word in there, that either evoke or replicate, and that sort of evocation of different experiences is an important component of this, aspects of the real world. And if we think about experience, the things that we go through, the reasons why, whatever profession we're in, we emphasise that our students have to get out there on placement, whether they're postgrad, undergrad, whatever. The purpose of that real experience is to learn. It's also to practice things, isn't it? It's that rehearsal. It's coming into contact with people. It's demonstrating that you've got competence. It's also developing confidence. But it's also about developing something that perhaps we might think of as wisdom. And maybe that's the bit that's really quite difficult for us when we're thinking about simulation. How do we develop that? So in one sense, if we kind of know what simulation's supposed to be, well, surely then outcomes are easy. We want to do the things that simulation is there to do. So surely it's the same as those real experiences. So from a learning point of view, it's the knowledge, it's the techie, non-techie skills, it's performance, and that could be assessed by people themselves. We certainly, with our second year students, when they do their cardiac arrest drills, we video everybody, we give them a stick with their video on, they go and look at it, look at the algorithm, work out what they did wrong, and then they come back without us going anywhere near them, and they're amazing second time around. So that actually how performance is assessed is part of all of this as well. We seem to emphasise this satisfaction thing, don't we? I think as academics we get hung up on this because of the NSS, and we want to do well, so we want to know if we're not doing things quite so well. But satisfaction also, really importantly, is about the simulated patients. If we use SPs, that actually they're happy with the care that they've received through that simulation as well. We also measure confidence. We often see that in a lot of the papers you look at. There's a measure of confidence has been used, often different measures, often something that somebody's made up. We don't necessarily think about wisdom. How on earth can we measure that? We'll come back to that a little bit later. So we might think outcomes are easy, but actually they're not that easy, are they? Because when we start then to think about the impact of using simulation, either as an adjunct or as a replacement for real life experience, then we need to think about who that's impacting on. We need to think about patients. We need to think about safety and quality goals, all of those kinds of things. And I think it seems to me that the state that sim-based education from a research point of view is in relates very closely to the translational science framework. And personally, I find this more useful than Kirkpatrick. But when we think about the outcomes that you need in order for the stuff that we're doing to be recognised as translational science, there are really three things primarily, and then the fourth one kind of comes in and almost wraps around all of that. So the first of those is actually the educational effects. In a way, that's all the stuff we talked about on the previous slide. That's the knowledge, the confidence, the skills, all of those things. But then at level 2 in this translational science framework, we do need to be thinking about patient care practices. And very usefully in translational science, they distinguish practices from outcomes. We often measure practices thinking that means outcomes will be better. Doesn't necessarily follow at all. And so we need to develop different evidence for outcomes than we develop for practices. And then McGahey and co. also talked about those collateral educational effects, the trickle-down effects. So the fact that actually if you've got some people undergoing SIM, what does that do for everybody else? And we'll come back to some of the evidence around that shortly. But that doesn't only include what impact me going through SIM has on the people I work with. It's also about cost effects, all of those kind of things. Can we actually retain people better if we put them through education programs and they feel more confident, they feel better cared for in their environment, better supported? Does it have that kind of effect as well? So there's a whole load of things that would not necessarily be directly attributable to the SIM, but the people having done the SIM can have a wider ripple effect. And I find that's actually quite useful when thinking about outcomes. So again, what I'm going to give you is just a flavour of some of the things that are out there around the T1 outcomes, knowledge, skills, competence, confidence, that little collection of outcomes. Mostly, these are the outcomes that are measured. So I've sat in on a few systematic review presentations since I've been here. I've also looked at some posters that have talked about systematic reviews, and there's a lot of this sort of stuff that's measured, isn't there? And we've done a lot of SIM studies. We measure a lot of this stuff too. And I wouldn't call this the low-hanging fruit necessarily, because it's not always easy to measure. It takes time, it takes effort, it takes planning. But it's the stuff we tend to think about first, maybe. So there's just a few studies there that are just some of the very many that are out there. If you put impact of SIM on knowledge, on skills, etc., you'll get lots and lots of hits coming back. So, for example, in both medical and nursing students, we're seeing some increase for medical students in knowledge about how they should be doing certain things, and for nursing students around their clinical reasoning scores. And a systematic review with meta-analysis showed that if you use mastery learning as part of simulation, then that had an impact across 41 studies. So there's something about actually how we do SIM as well. But again, it's all framed around what have people learned through this? What are they able to do as a result of the SIM? Great stuff, really, really important, but we also need to move the science on, don't we? So in terms of translational level 2, this is actually about care practices. So again, there's been some work done in this area in particular. So there have been studies that have shown that IV medication error rates can decrease. You've got all the references are there. In the obstetrics area, that time between diagnosis and delivery in women who've got cord prolapse, people have been able to demonstrate a significant reduction in that time. So this is all really positive stuff. This isn't necessarily saying anything about the patient outcomes. This is absolutely about the care practices, and this is where it's important to be able to distinguish between those. And also, you know, things like charting of vital signs, pain scores, all of those kinds of things. Again, in a rural hospital in Australia, those significantly improved after, in that case, putting the whole hospital through SIM. Rural hospital, Australia, small, no medical cover, 40 staff, 40 registered nurses, and the managers decided they all needed to do something because patients weren't necessarily being managed as they should be managed. So again, some improvements seen there. And taking SIM out into general practice and identifying that actually the GPs and the practice staff themselves identified that they made changes. They checked the equipment more often. When somebody new came in, they made sure they knew where the equipment was and that it worked and that things were in date. Self-reported. So again, we don't know quite whether there were changes in care practices. So we always have to have a note of caution there. But again, care practices changing, that's a step up, isn't it, from just measuring what's going on in that SIM setting and what it's doing for the learners themselves. There's been, in more recent years, a lot more emphasis on patient outcomes. What can we do to measure whether SIM has made any impact on patient outcomes? So these studies generally are pre-post studies. So you collect data before, you put the SIM in, you collect data afterwards. So that says something maybe about the type of studies and the confidence we might have in those studies. We don't necessarily know whether actually it was the simulation that made the difference. For some of the studies, they did much more robust reporting. And the study on the previous slide about vital signs, the investigators there used time series analysis to look at patient charts for 6 weeks before and 6 weeks after the intervention. That's a really expensive way of finding out whether actually what you've done has made any difference. Time series analysis is a really useful method, and it does show whether if there was already a trajectory of improvement, if the SIM made no difference, then that angle will stay the same. So it wasn't the SIM, it was something else going on. Maybe somebody had read a paper and said, look guys, we need to change what we're doing. So there's something about actually how we measure what we're measuring to really show that things are making a difference. So these sort of things showing that central line CLABSI in medical ICU actually reduced following a period of SIM, central venous catheter pneumothorax reduced. So all of these kind of things, fantastic, but maybe we do also need to think about better ways of capturing that so that we know that it was the SIM that made the difference and not something else collateral. You know, I think we don't live in a bubble, do we? Papers get published. People go to a conference and hear various things, and they'll change practice maybe not because they've been through the SIM. So we need to think about all of that as well. And again, interestingly, on a slight sideline, Bridges and Co. did a systematic review and a meta-analysis when they were looking at outcomes from assessing somebody in a SIM environment and assessing them in the workplace, and they found those outcomes were equivalent in terms of what happened to patients further down the line. And again, that was an attempt to say, actually, can we do this assessment in a better place than in the workplace, where there are all sorts of risks to patients and so on. So a slight sideline to where we're looking with all of this, but again, that's a really interesting paper if you're interested in that particular area. So we don't know. Yes, there's evidence out there, but we still don't really know whether it's the SIM that's made the difference there. So need to think about all of that. And again, what we're talking about here is association. We're not talking causation. When this happened, this seemed to happen as well, rather than actually due to this happened. So again, thinking through exactly what we mean by that. So just thinking about those drip down effects, trickle down, collateral effects. There's not so much evidence in this area at all, and I guess in a way it requires a much broader net to be cast in order to capture these kind of outcomes. And I guess I like to think about these collateral effects more along the lines of, well, actually, when we're setting up a trial, we tend to run a process evaluation alongside so that we can identify exactly what else happened during that trial and what are the things that we need to take account of when we're presenting data, when we're actually interpreting our findings. And for those of you that have an ICU type focus, the Matching Michigan style study and the amazing process evaluation that Mary Dixon Woods and co did alongside that, that's actually where the interesting data was. And so when we're thinking about these collateral effects, then maybe we do need to think a bit more broadly about, okay, so maybe this group of people have gone through the SIM, so where might those ripple effects be, and how would we actually find those? What would we do to do that? So again, there's been a few studies in this area, and you'll see from the references they've mostly been carried out in this decade. So it wasn't necessarily something that people were thinking about before this. And so in one study, when they actually were looking at central venous catheter insertion skills, they found that the junior trainees were significantly better at those skills if they'd actually been trained by seniors who'd gone through simulation. So again, that's an interesting sort of trickle-down effect. And another study looked at, again, CVC insertion. This is a high-risk procedure, which is probably why it features so much in our sim literature. But again, this particular second study looked at healthcare costs, because that's part of that trickle-down. If you can put simulation in, and then the healthcare costs are cheaper. Now, the jury, of course, is still out about whether it was that simulation intervention that made the difference. But if we can actually start to collect those data that say, well, actually, if we're reducing infection rates, what does that mean in terms of costs? So sometimes just having a repertoire of all of those costs at your fingertips, a bit like when we're costing research grants and we say, well, I know how much a day of this is and a day of that. Well, actually, starting having these costs at your fingertips or knowing where you would go to get them might be quite important. Of course, the important thing about these sort of effects is that it widens considerably the places we can go to look for funding for the sort of research that we want to do. And that's a really important component of all of this, isn't it? The funders who will fund sim-based research are actually quite narrow at the moment. So if we can broaden sim as an intervention and the impact that that may have, you've then got opening up sort of NIHR research for patient benefit, all of those kind of areas. But again, we need to get the science absolutely right, because the people who review those studies won't necessarily understand the sort of research that we do. So we do have to make sure that we've got all the ducks lined up, and that if we're going to talk about cost effectiveness, we understand what costs are, what effectiveness is, and how those two come together, and we talk the right language. And then you have experts on your team who actually can measure cost effectiveness, and we're not all pretending that we're experts in everything. And those kind of things are really important as well. But again, for this particular study, they looked at the annual savings because their catheter-related bloodstream infections reduced. And then they looked at the annual sim costs, and they compared actually what difference has this sim made, because sim is not cheap, is it? But compared to bloodstream infections, sim is actually very cheap. But you need to do the maths, don't you? You need to do the sums, and you need to do that in a way that is robust, and that a health economist looking at that will say, yeah, actually they've used the right figures. This does make sense. This does add up. They're not trying to blind us. But what they found in this particular study is that there was actually a 7-to-1 return on investment from putting sim in place. Now, those are pretty impressive figures, aren't they? So if we can start thinking a little bit more in that line, if we expect things to change, what do we expect to change? And maybe sometimes the cost of something is the driver to do the study in the first place. To say, well, okay, how can we bring those costs down? Is there something about the way we do sim that might bring those costs down? So you start at the other end of things, if you like. Rather than looking at this as the ripples, you actually decide that that particular ripple is maybe a really important outcome, potentially, for sim. And suddenly we can then start to tip the balance in terms of that whole return on investment argument, and actually where that investment should be coming from to get these things happening. And once you can start presenting boards with those kind of data, then that's when they start saying, well, why aren't we using sim more often then? So it's kind of getting the arguments running in our direction. And interestingly, a systematic review which reported on data from 967 papers found that there were so many missed opportunities to report costs. So again, the reference is there. Go and have a look at that, because actually that gives you some detail on the sort of costs that you could be thinking about when you're planning your next foray into research. So those sorts of things are really important, and I've already mentioned that this whole collateral, the ripple effect or the trickle down, we need to think a bit differently about all of that. And maybe because there's more argument out there now that says this can work, this can have all these other effects, that allows you to put a paragraph in your grant application that clearly says, this is not just me having a bright idea and deciding I want money out of this source instead of this source. Actually, there's some science around this now, and that's actually really important. There's also a broader outcomes agenda, isn't there? And the work that was done a few years ago now, commissioned by the GMC around junior doctors and what the struggles that junior doctors were having, they found that actually there's a lot of things that they were quite unhappy about, and actually not only unhappy about, but really suffering because of. Things like prioritisation, dealing with angry and confused patients, dealing with complexity, uncertainty, and you can start to think, oh, simulation, we could simulate these things, but also dealing with their own emotional response and self-care. And in response to that particular piece of work, which was done by Lynn Munro and colleagues over in Cardiff, the GMC and the AMRC together said that clinicians know when not to take action. And actually that's really important for us to think about from a sim point of view as well, isn't it? How do we actually set up our scenarios so that the actual ideal outcome is that they don't intervene rather than that they do? And that's a really interesting challenge for us, isn't it? So they were concerned that actually they need to know when to take no action and actually how to move forward when the guidelines and the protocols don't cover the situation. So in other words, when is it safe to step off the guidelines? And how would you rationalise that? And how would you present that argument? And I know years and years ago now, coming to ASPE, unfortunately, because of my lovely Monash job, I'm not often around at this time of year. I've usually gone for find some sunshine down under. But I remember coming to a really interesting, one of the parallel sessions a few years ago, when I think they were fairly junior doctors were talking about some sim that they'd been involved with where they had to present things to the board, and that was the simulation, presenting an argument to the board about sort of a difficult situation that they were having to manage, and they were needing to get more resources out of the hospital board. And it was a really interesting piece of work, and it really stuck with me. So there'll be pearls, not from this session necessarily, but from the parallel sessions that you will pick up and just take back and go, wow, can't we do that? So knowing when to do nothing and when to do something that you don't have a guideline for is really important. So what does that mean? Well, Hilary Neve and Sally Hanks would say this is all about capability. A couple of years ago now, they did a really good workshop in Prato, all around capability and how you develop capability and how you measure it. And capability is that whole thing when you've got lots of different competencies that you may have signed off individually, but what you're needing to do now is bring all of those together in a situation where there's lots of unknowns, it's complex, there's things going on that maybe you've not encountered in quite that way before, and actually working out how you integrate your actions. And Hilary Neve likens this to the MasterChef moment, you know, that moment when 1 week they've been cooking in the kitchen with a recipe that they've devised and they've practiced it lots of time at home. Suddenly they're in a factory with hundreds of people to feed, working with a team they haven't worked with really before or cooked with before, using equipment they've not seen before, and using ingredients that are just presented to them. And actually this is where those of us watching will say, okay, well these guys are capable and these guys clearly are not. Or it may be individually somebody's capable, but they're in an incapable team. And I always think that's actually quite a useful analogy to think about. But there's lots of challenges, aren't there, with assessing capability, because if we're trying to work out how people pull things together, and we know it when we see it, don't we? And I can even remember, you know, with students, particularly with when I was running the ICU course years ago, you would know those students who just got it and could knit everything together. And we used to use the word capable. They're very capable. And I always like when I receive a reference, if it says they're very capable, I think, oh, this is good. But it's just one of those things, isn't it, that we're used to actually assessing certain skills. So actually, how do you assess capability if that's an outcome that you want from your sim? And again, we're cautioned that actually if we're too overly objective in our assessment of capability, actually we're not really embracing real world, are we? So that's a real challenge for us in terms of capability. And so maybe this is where the entrustable professional activities come in as a potential marker of capability. I think EPAs are really, really interesting. As a non-medic, I kind of really latch onto them and think, yeah, actually, we don't have quite the same situation in the other professions where somebody's prepared to be at home whilst the people are managing things, because we've got people around. So entrustable might mean something different for other professions. But there is something about, as the senior, I'm prepared to not be there because I trust that you know what you're doing. So that may be something around capability, and I'm just throwing this out there as, you know, this is the challenge maybe. How on earth would we do this? We don't find much evaluation of EPAs. There's a little bit out there, but not that much. Maybe people just aren't writing about it. I don't know. But it is also about those non-technical skills, isn't it? It's the leadership, it's the pulling the team together, not only being part of the team, but working out actually with all of these competencies that have to be demonstrated with this single situation, who's the best person to do what. And the immersive sim going on was fascinating to see how some of that was happening as well. And so we don't have evaluation of capability. We don't really know quite how we grasp that. But there is also something about sim performance. And I think we're starting to see a little bit about capability, but people just not using the word. There's work being done about whether simulation is a predictor, how people do in sim is a predictor of how well they do when they get into the job for real, and what impact does that have further down the track. So that's certainly something to think about. But actually this whole agenda about outcomes is broader than just simulation-based education, simulation-based teaching, because it's not just used to train or to educate, is it? And this is where we need to think about this thing called the regulatory sim, which some of us are more involved with than others. In Australia, we've just been writing regulatory sims for internationally qualified nurses. And I know Claire is very involved in similar work over here, so she's been helping us in Australia as well. But just thinking about why we use sim, that actually alerts us to different sorts of outcomes. And if we think about the ways in which we use sim, sometimes we're just using it as formative, and it's much more embedded into the curriculum now, isn't it? So students are more likely to go through various sims that they're not high stakes, they're not pass-fail, but they're just ways of allowing you to learn. And how many times have we had people sent to us in education because something's gone wrong? So, oh well, you know, send them off for some education, that will fix it. It's a worry, isn't it? So there's a learning and development kind of agenda around all of that, isn't it? But sometimes with sim that's formative, what we're doing is we're wanting to familiarise people. We want people to know what the kit feels like and to know actually how to handle things, how to juggle things, all of that. So it's about practice. It is about confidence, but we don't need to measure it at that stage. It's just about people feeling, yeah, I can go into this situation and I won't be totally floored by it. There's something there also about proficiency. And so the debriefing is really crucial then as well, from the point of view of people learning. But also if you score people, if you use OSCE scores, well, okay, what was really going on there? So sometimes that's when the use of video to supplement the scores. And this is what happens with our second year students when they're doing their cardiac arrest drills. They know what they did wrong, but the video tells them at what point they went wrong. And so being able to look at that is actually really valuable for them. So that's important. But then the stakes rise, don't they, when we come to a summative assessment. Now, I would say the stakes aren't quite as high as they are for a regulatory assessment, but it's important here that we also provide feedback. So we are still on the learning agenda, aren't we, with summative assessments? Because summative assessments are often just an end point, but you're going on to something else afterwards. So it's important that people get feedback. But it's also people being assured that, okay, you've passed this, so that means you're ready now to go into practice in that particular area. But then when we get to the regulatory sim, what are we most vexed by? Well, it's actually the validity and the reliability. It's knowing that actually this really is measuring what we think it's measuring, that actually if we say this person is competent to go out, in our instance as a registered nurse, that they really are. So how do we get that right? Much more emphasis on reliability and all the psychometrics around what we're measuring. and also making sure that when people come in, this is high stakes. So for some of the students, particularly in Australia, they will have come to Australia, they'll have only been there maybe for a few days before they come and do this sim. So they're not sponsored by an NHS trust like they are often in this country. And so they're literally, we're throwing them into an environment in which maybe they don't really understand the English that well to know what instructions they're getting. So we have to think quite differently about things like equity, and then in the context of all of that, how do we still assure the employers that these people are safe? So regulatory sim is quite different. We don't debrief after a regulatory sim because actually we're not bothered with what they've learned from it. I found that really difficult when we started doing all of this. Whoa, hang on, surely we need to give feedback. Nope, that is not the purpose of it. The purpose is literally, can these people do the job? Are they safe? And so it's a really interesting dynamic. And maybe again, as you move along that trajectory, then the emphasis really is on that capability. But again, we don't always necessarily assess that. The other dynamic that's in all of this is, of course, sim as placement replacement. There's a lot of emphasis on this now, certainly within the nursing profession, because the NMC have taken the bar off of how many hours students can spend in sim instead of going on to placement. So there's a whole lot of different dynamics now come into play, and you can use it as placement replacement both in terms of formative and summative and regulatory. So the things that we're now doing in the sim lab for a regulatory sim used to happen in practice. So people used to get signed off in practice, and now we've brought it into the sim lab. So it is actually a little bit different. So just thinking a bit about that whole placement replacement thing. Yes, there's work that says actually you can get similar outcomes if you replace up to 50% of your normal placement with sim, then actually you can still demonstrate the same kind of outcomes. Okay, but what about those softer outcomes? What about the interactions that people have on placement when they're actually with patients, with families who are really anxious, who are angry, all of those kind of things. We build a bit of that into sim, but it's not like being in a ward. Interestingly, when I was over in Israel a few years ago, I had the privilege of going to Amitai Ziv's sim center in Tel Aviv, and I don't know whether anybody else has been there, but it's quite a place. It is a full building that is just simulation, and it's a really interesting place to walk into because there are lots of simulated patients there wandering around in hospital gowns and dressing gowns and things, and you think you're in a hospital. So in terms of that whole kind of ecological validity, actually doing, having sort of sim as a replacement, but somehow getting that ecological validity, the actual things they did in there were no different to the things we were doing, but somehow having it all together and walking in, it did feel very different. Really, really interesting. Of course, they were quite keen that we might want to buy some of their services, so I was given the sell. But it was an interesting time, but that's what stayed with me. That actually this feels a bit like a hospital because there's like an outpatients area, and then there's a ward and things. So really, very, very interesting. But the key thing really about all of this placement replacement and what we might mean in terms of outcomes from that point of view is actually just getting clinical partners actively involved. And also getting patients involved in both the design and identifying what the outcomes are, what's important. To the patients, it's important that that student is willing to come up and talk, not that they actually know how to do A, B, or C. It's not about actually doing the vital signs, because actually they're generally done by the healthcare assistants anyway, but it's actually just that human stuff, isn't it, that we often miss out on. And there's some interesting work being done particularly in OT, about what are the quality criteria if you're replacing a placement with sim. And then those particular authors talk about that authenticity. How do you make it authentic? Complexity, interaction, assessed using the same objectives as you would use in placement, which is an interesting one, isn't it? And how do you do all of that? But also that mix of sim modalities so that they don't just go in day after day and do the same things each time, but it feels more like a placement would feel. So that's actually really important. So where do we go from here? Well, there's something, isn't there, about core outcomes. you know, in the clinical research world, we're very focused on core outcomes these days, so that if we're doing studies about weaning from ventilation, that we all measure the same things. Otherwise, the thing that we found from various systematic reviews in our field, and from some that I've just heard this morning, is that actually they're too heterogeneous. You can't meta-analyse very many of the studies. We've all measured different things. And so it may be something that, and this is, I guess, just a challenge I put out there, that maybe this organisation needs to think about, is there a core outcome data set that we could use? If we're going to measure X or Y, should we all use the same thing? So that at least then we can compare, and we're not comparing sort of, you know, apples and bananas or whatever. And actually it's really important for translational science. If that's where our discipline wants to go, then we've got to get more serious about what our outcomes are and how we're measuring them, and how we can then think about impact. Also, in terms of debriefing, that's some work that we did recently with a systematic review, we found, and the Bs are all the bespoke tools that people use. We looked at debriefing frameworks, we looked at outcome measures, and for them, this is just part of our table. But just look at all those Bs on there, those red Bs. Actually, people had just tweaked things. Or, well, I don't quite like it, so I'll change it and I'll measure it like this, or I'll come from this slightly different angle. Not with a good rationale necessarily for why you couldn't use what somebody else had used before. And when we were Tom Gale and I were starting to look at debriefing, I think it was Kirsty Forrest who said, for goodness sake, don't develop another debriefing model, because we've got too many already. And there is something about that, isn't there? And I guess that's a challenge for all of us. How do we get away from this mess, really, which meant that we weren't able to do the lovely things that we might have been able to do with the data? So in terms of where next, and we've already prefaced quite a lot of this already, we do need to measure what matters, and therefore we need to simulate what matters. And we need to think about actually what matters to our health partners. What sort of things do they need people competent to do? But also, if we're talking about SIM as a way of changing what's happening in health services, improving quality, improving safety, then what things are they interested in? Not the things that we think are the right things to measure, but also thinking about patients as well, and drawing patients into all of those discussions about what is it that isn't quite going right at the moment. So we need to build that into our SIM. Thinking about that, thinking about capability as a more explicit outcome, and thinking about how do we measure. Where next does have a question mark, because I'm not giving you answers, I'm just sort of throwing some ideas out there. And if you want to go down any of these paths, I guess what I've given you is some of the evidence as to why we might need to think about these things a bit differently. We do need to think perhaps about that whole idea of a core outcome data set. But also, certainly in our neck of the woods, we've got EPIC coming in, which is an amazing patient record system, which will integrate all the records across primary care, secondary care, ambulance, and so on. And suddenly, we're going to have a data set that's a lot cleaner. So if you're now starting, if you're looking at patient outcomes, one of the challenges always is that you're using data that was never collected for research purposes, and it's incredibly dirty data usually. And not only it's got missing data, but actually a lot of it doesn't make sense either. So we tend to rely for our patient outcomes work on data that isn't clean enough for our purposes. So these advances, we need to capitalise on that. We need to know what's going to be in these data sets so we can say, right, okay, we can use these to look at whether SIM's having any impact. We've already talked a bit about the translational science work. It is important with that ripple effect that we have a note of caution there. There could be some arbitrary quota setting that says, oh, well, maybe only 20% of people need to go through the SIM, because actually that'll be enough, and then the collateral effects will happen magically. And so therefore, you can cut down the number of people that go through SIM. There we go. So we just need to be aware of those kinds of things. We can be hoist by our own petard if we're not careful by promoting some of these ideas. But also I think we do need to get a bit smarter about outcome measurement. We tend to measure outcomes when we're doing a research project, when we've got a grant, but we need to work out how do we build outcome measurement in routinely so that this is just what we do. It's not just something we do when we've got a research assistant that we've got paid from a grant or whatever. So that's actually really important. I was really pleased to see in the standards when they came out that the final standard, which I think I guess I would say probably needs to go up the top, is that there should be a clear alignment to the wider organisational and stakeholder needs, acting as a quality and risk management resource to improve patient safety and care quality. And interestingly, we're certainly starting to see now that the CQC will talk about these in situ sim in their reports, and that's actually a real win, because that's a bit like having an impact case study for REF, isn't it? It's actually saying, you know, if the CQC think this is valuable, then we're getting there, aren't we? But maybe in terms of accreditation, we need to keep flying the flag to actually get people needing accreditation, because then they've got to meet standard 21. And so that then suddenly becomes everybody's business, doesn't it? So just a few challenges to throw out there. I was never intending giving you any answers, but that's all that I wanted to say. I'll take you back to my lovely seaside scenes in my 2 workplaces, but I'm happy to take a couple of